But what I want to tell you is that in Maryland especially, I'm working in Maryland. Carroll is a hospital that's outside of Baltimore. And Maryland, is anybody here from Maryland? The one guy who was here, Brian Silverstein, just left, but he's going to be back. Maryland's a very, very interesting state because they have a very interesting payment system in Maryland. They actually have a rate-controlled system where the state sets all the hospital rates. They've actually got a waiver from CMS, and they've had this in place for about 30 years now, where they can actually set all the hospital-based rates. And while this may sound like socialism, and in a way it sort of is, it's really interesting because it's a laboratory where we can actually explore some of these things that we're talking about. So let me give you an example. The hospital that I've been working at for the last 3 years, we've been on this thing called TPR, total patient revenue. That is essentially a fixed cap for all hospital-based services, both inpatient and outpatient services. So this has allowed us to adopt an accountable care population health capitation model for our hospital services and actually get into it and actually start to build the infrastructure. And for us, it's been very, very successful. We've reduced our utilization dramatically, and we have achieved dramatic financial results. The thing that we're looking at in this future is they're calling it PBR, which when I was in college stood for Pabst Blue Ribbon Beer, but this is actually called population-based reimbursement. They're actually going to implement a reimbursement model that is population health in its essence, which is essentially saying you hospital will get a set of zip codes, a geography, and you will be responsible for managing the health care of that geography. And if there are any shared savings at the end of the year, you will actually be able to share in those savings. So that's where we are moving forward, doing all these things. We are totally bought in on this 100% as a strategy. As a small hospital, we both worked in small, medium-sized hospitals, and we were able to do this in our communities. And it's two very different communities and two very different examples. Like I tell you, I'm just in the throes of starting to put this together. We've been very good on the readmissions management, utilization management. In terms of the real population health management, we're just starting to do it now. Okay, so here's what we're going to do. We're going to transform the patient experience. The traditional patient experience has been very episodic and very hit and miss. You have a segment of the community at high risk for health services. They experience a healthcare event. They then seek a service. They receive the unit of service. For that unit of service, they are discharged with minimal transition assistance, and they are sent out there until another event may or may not occur. So this is the most important slide. I think there's two slides in this presentation that are important. I got one, and he's got one. And usually, when I give this presentation, I use his slide. I have completely stolen Bill's slide. You know what I'm talking about that shows the savings, okay? So, and that to me is the most dramatic, so I won't take his thunder away. But population health management, very, very simple. It's the Willie Sutton theory. Why do you rob banks? You go where the money is. Everybody's seen this, right? The top 1%, you know, of healthcare is of population is about 22% of healthcare expenditures. The top 5% is about 50%. This is national, and this is where it's focused. All you do when you start population health management, you start at the top 5, 4, and 3%. You find out who those high utilizers are, the ones that spend the most money, and you focus your resources like crazy on those people. And Bill's example will show you how an effective population health management system was able to do it. I heard this concept mentioned earlier too, this whole concept of risk stratification, all right? One of the things on the first slide, which I sort of skipped over, is that in the past we sort of treated everybody the same. They showed up at our door, we treated them, and that was it. Population health is based on treating everybody differently depending on where they fall on this 2x2 axis. So if you look at this, and most populations actually fall out into these percentages, believe it or not. So for example, if you look at perceived health on the vertical axis and objective health on the horizontal axis, most people are in the upper left. They think they're healthy, and they're healthy. So, and most people stay there. So that's 80%. Then you have the worried, well, these are people who think they're sick, but they're not. And this is very interesting. These are the people, these are your high utilizers. These are the people that you find going to your ER. By the way, if you ever look at your ER utilization by individual, if you have an individual identifier, you may find that you have people visiting your ED. We found this, believe it or not, more than 100 times a year, okay? So that's a good target. And one area there that I'll just touch on is that these people have to do with behavioral health and access, but a lot of behavioral health issues. And you know, we've sort of retreated from behavioral health in the healthcare system, but we put a lot of focus on that now. Then you have the people in the upper right. These are the people who are undiagnosed. They're sick. They just don't know it yet, and you screen them. But the bottom right, this is where we're going to focus. These are the people we love. These are the sick people, the chronic sick, high utilizers that spend 50% of our resources. This is what I call our frequent flyer club. Like I said, you may even drill down even more. I think Bill's example shows you that they focused on the top 3%, but you could even drill down to the top 1% to expend a lot of resources, and these are the people that you're going to treat different. These are the people that you're going to set up special clinics, special programs. You're going to go out and find these people in the practices. You're going to enroll them in disease set. If they don't have a primary care physician, you're going to put them with a primary care physician. These people, by the way, when they come to the primary care physician, they get same-day guaranteed appointments, and those appointments might even be longer than your normal 5-minute appointment. So the idea is you take your resources, you focus them on where they need to be. Physicians and hospitals assume responsibility for managing the health of the entire population. In the model that I talked about in Maryland, it's not a fully capitated product. This is a difference between now and what we saw 20 years ago. It's a shared savings model. So we're not at risk per se for all of the expenditures, which is where we got into trouble 20 years ago. But if there's upside savings and downside savings, we can participate in that. So we screen community members for health risk factors, and we put them into 1 or 2 categories. The idea is keep healthy people healthy, make sure sick people don't get any sicker, and they can access the system. So what are we looking for with population health? Everybody is involved in this at all levels of the spectrum. They're on deck with frequent flyers. Coordinated information systems, obsessive focus on the continuum of care from pre to post, and I'm going to show you how we're sort of restructuring our health system to do this. Drive care to the lowest level, reduce readmissions, provide wellness at every healthcare touch point. When they come into the ED, when they come into the urgent care, when they come into the retail clinics, provide longitudinal chronic care management whenever you see these people. So I won't go into this, but obviously you need 3 major areas: IT, patient-centered medical home, and chronic disease management. These are all of the things that we're starting to put together. And I think, Bill, you're going to go into some detail about that, right? So here's a problem. How do you balance volume versus value? Okay? And we're having this problem with our ED doctors, because you know why? The ED doctors, they're still paid by more and more and more and more. We're trying to get them to say, look, manage your utilization. If there's savings, we'll share it with you. So that's a real challenge. Okay, so this is sort of how we look at putting the whole system together, community health system and post-acute. In the community, what goes on out in the community? Disease management, behavioral health, pharmacy, health system access, patient navigation, care management, and post-acute after their discharge. So these are all the services and functions: access, patient navigation. Patient navigation is doing that, helping the patient navigate through the system, and case management, focusing on case management. Does anybody do 24/7 ED? Did you do that, Bill?
Yes.
Okay. Very, very effective. And then, of course, post-acute, whether you partner or whether you build it, it's very important to get involved after the system. You put it all together, the idea, let's drive care to the lowest cost setting, either pre or post-discharge. This is the epic fail. This is what we're trying to avoid. This is what hospitals are facing right now. If they get readmitted, there's going to be penalties and more penalties. So the idea is to make sure that you're intervening with the patient before they get discharged, after they get discharged, to make sure that they don't get readmitted. And then putting it all together out in the community, we do disease management. We go find these people, set them up in the program, do care plans, and manage them. Call centers 24/7, access, making sure they can get in at any time, that they can call in somewhere and find out, should I go to the ED? Can I get an appointment? What's the most appropriate place to do it? Then they hit the health system. Once they hit the health system, we navigate them through. So they're doing it very effectively, very efficiently through the entire system. Case management, of course, discharge planning. Post-acute transition management, this whole idea of managing patients through the end of the acute care stay and into the long-term post-acute system. PAC networks, that's post-acute care networks. where you actually go out and set up networks with SNFs and rehabs and LTACs to manage that care. And this whole concept of the SNFist that I think Bill's going to probably talk about a little bit later. So just sort of closing off my introductory remarks, this whole issue about accountable care. And who's going to do what? What's going to be the role of the payer? Is the payer going to keep the risk and do what Care First and Blue Cross in Maryland did, which is essentially incentivize providers based on top of a fee-for-service payment? Are they going to shift the risk to the providers? We heard today a little bit of talk about the premium. And does the provider start to take more and more of the premium dollar? What's going to be the role of the hospital? And this, to me, especially for us in the hospital industry, is a real scary thing. Because what you're seeing now in terms of the payment mechanisms is the payers are encouraging the primary care doctors and the ACOs to manage utilization. In other words, if they manage down hospital utilization, they get rewarded. The dollars are shifting from the hospital to these providers. So for example, this network that I'm familiar with in South Carolina, they actually are getting paid by the payers to manage ED utilization, and in the local hospitals, ED utilization fell 43% in 1 year. So, we talked a lot about, primary care and lots of, primary care visits. In a way, you want primary care. You want these people to be accessing primary care because that's the least expensive care. And then, of course, there's the whole issue of post-acute and rehab. So where are we going? Probably larger consolidated providers focus on coordination, collaboration, communication. When it comes down to it, that's all this really is, population health, is finding the people and making sure that all the dots are connected and that data and information is exchanged. More comprehensive continuum of care from the beginning to the end, and finally, managing the health of population as opposed to worrying about volume. And what we're really seeing, and this is the question for us in the hospital industry, is that very successful, large, physician-driven models are taking the lead. So if the physicians can ever organize themselves and put themselves together in large groups, this is a big threat to the hospital. So the question we need to ask ourselves is, can we and how do we integrate with hospitals? I worked in 2 markets, and there's some people I know in this room who are familiar with this, where physicians actually went out and opened their own inpatient hospitals to compete with hospitals. So if the physicians can actually manage the care and be effective at driving savings through utilization management, it's going to be a big challenge for us. But what we did as a community hospital, and what Bill did in his hospital, is to say, no, you know what, we're not going to be a marginal high-cost service in the healthcare system. We're going to get out in front of this, we're going to reconstruct our healthcare system, and we're going to actually build these competencies. And that's what we're actually doing right now. So with that, I'm going to turn it over to Bill, who's going to show you how this actually works.
Thanks very much. I appreciate that, Bob. For the last almost 2 years, I've been a consultant focusing largely on accountable care organizations. But before that, I was a hospital CMO for multiple systems, including the last system where I was Chief Medical Officer, Chief Operating Officer, and then Chief Executive Officer of a small 3-hospital system in Springfield, Massachusetts. Springfield, Massachusetts, if any of you saw 60 Minutes on Sunday, it was described as the most gang-infested city in the United States. The city of Springfield is really a special problem, huge homeless problem. In a city of 100,000 people, our methadone treatment program dosed 973 methadone addicts every day, meaning that a little more than 0.85% of all the population of Springfield is on methadone. I don't know what percent would be on heroin. They say it's several percent higher. This is really a desperate situation. The hospital was a dish provider, and we had incredible competition with a wonderful hospital about a mile away called Bay State Medical Center, which is always a 100-top hospital in the United States. When I got there in 2007, they had a Medicare Advantage program, which was full risk and full capitation. and they'd been kind of managing that since 1996. I came in 2007. That program was one of 10 in Western Massachusetts. 9 of them went bankrupt. And this hospital that I'm about to describe, and actually it's a system, was losing money every year and was about to close. And we decided that the only way that we could survive is if we did something dramatic. And we decided to go full risk, full cap, build up our accountable care organization as big as we can, as big as we could. And I'm going to present to you some data from one of the 2 Medicare Advantage programs that we ran. This one is from the Tufts Health Plan, which had 5,100 members. And we also had one with the Fallon Health Plan, the data of which I won't describe, but they're quite similar. The total program was roughly $100 million. I'm only going to describe the Tufts part of that. Now, we were really in an ideal position as a hospital because we had a continuum of care. I say we're a hospital because I'm focusing on the acute care hospital, but we also had a psychiatric hospital, the biggest in Massachusetts, a rehab hospital, the second biggest in Massachusetts, a home health agency with 65,000 visits, which we grew to 80,000, a hospice, and several nursing homes. So we really were lucky. We really had the continuum of care. Well, I said I'm going to talk about one aspect of our full risk, full capitation Medicare Advantage program. Medicare for that 5,100 patient group paid $70 million per annum. Tufts Health Plan would take $7 million of that, leaving us with, for administration, leaving us with $63 million. We then decided that the only way to build up our specialty network, we had almost no specialists, was to pay any specialists that joined our IPA at 120% of Medicare if they saw our patients. We also decided to partner 50-50 and split any shared savings 50-50 with the primary care doctors, not with the specialists, and if people have questions we can talk about that later, but only with the primary care doctors. We didn't have the money to employ any physicians. There was a group, however, that employed some physicians. We started out with 23 physicians in 2007, primary care doctors. By 2010, we had 147 physicians who joined, largely because of the shared savings, and I'll show you some of the financial factors there, but we were able to grow our primary care practices from 23 physicians to 147 in 2 years without employing anybody. As I said, we had a community hospital. Bob alluded to our sniffists. Those are specialists. It's a term that I find repellent. The term sniffist is that, but I found hospitalist repellent years ago, that term too. So maybe I'll grow to be less repelled. But they're basically physicians, typically geriatricians, who aren't the ones that come in once a month and are retired already, but just kind of futz around with patients every once in a while. These are people who've dedicated their lives to caring for nursing home patients and keeping the stays in the nursing home as efficient and short-lived as possible. We developed a number of clinical programs. For instance, the most important one I would say is the real-time physician availability for urgent needs. Bob talked about focusing on the top 5% or 1% or 3%. We found that 3% of the patients in the accountable care organization incurred 49% of the cost. So in a population of 5,100, that means that roughly 150, 160 patients incurred 49% of the total cost. We knew that if we focused on them, we had a chance of making a lot of money right away because it was full risk, full cap. So we would, every penny we saved, we put in our pocket. And also then perhaps we could use those savings later on down the road for primary and preventative care, which doesn't have a good payoff. I'm a pediatrician. I ran general pediatrics at Boston Children's Hospital for 17 years. I'm dyed-in-the-wool primary care person. And I can tell you that the short-term payoff of primary care is very, very low, very, very low. If I give a vaccine to somebody to prevent pneumococcal pneumonia, I'm not really going to save that much money over the next few years. But if I prevented admission of somebody with chronic obstructive pulmonary disease, I can make a lot of money if it's all going in my pocket. We emphasized the patient-centered medical home. We had access to this special on-call system. Everybody in the emergency room, all the doctors in the emergency room were strongly familiar with the 3% of the sickest patients and knew those patients backward and forward. So if they came in they were going to get very good care because the people we had asked them as CEO, COO, and CMO, I told them in a dictatorial fashion that they would know those patients. And the special on-call physician was in charge of them across the continuum. So if somebody came in who was one of those 3% with diabetes, I'll give you a real example. Here's a real case. Mary, 76 years old, comes in. She has a blood glucose of 500. Obviously, with diabetes, she definitely makes the criteria for interqual to be admitted to the hospital. The ER doctor calls the real-time on-call physician for the ACO. The physician typically would come in and say, Mary, you know, the last time you were here, we didn't admit you because we just kept you in the ER for about 6 hours. We gave you fluid and insulin and your blood sugar corrected, and you were able to go home with your daughter. Do you want to try that now, or do you want us to admit you? Every single time, Mary would say, I want to go home with my daughter. Let's give it a shot. So instead of spending $10,000 out of the capitated pool, that money stayed in our pockets. Instead, we'd pay a $300 ER bill or a $1,700 observation stay. We wanted to be sure that we kept patients in our low-cost network instead of going to the expensive teaching hospital. So that's why it was important to recruit the primary care physician. Pardon me? Oh, yeah. He's telling me. I don't know how to use a laptop, clearly. At any rate, dedicated hospitalists, very important to keeping the cost of care down. Having a rehab facility either owned or one that you have an agreement with. For instance, typically if you don't own a rehab hospital or a psychiatric hospital, as an ACO you might enter into a discounted fee-for-service arrangement with those facilities so that you would pay them less in return for sending all your volume to those facilities. We really jumped in, as you can see, under home care. In the first year that we looked intensely at home care, we went from having 65,000 visits a year to 82,000 visits a year. And that really was very, very helpful, as you'll see in a little bit. That's one of the key factors in decreasing admissions. And I can tell you that we were willing to send home health workers for whom we did not get reimbursed. So for instance, we would send a respiratory therapist to the home of a patient with chronic obstructive pulmonary disease, even though Medicare would only reimburse for a visiting nurse. And that home health respiratory therapy visit was worth so much money I can't tell you, because for instance, she'd take a patient with chronic obstructive pulmonary disease, one of the 4 most important diagnoses that cause people to be in the 3%, and train people to, when they walked with their walker, every time they put their walker down, she'd say, you take a deep breath, and as you're exhaling, purse your lips, puff out your cheeks. That increases the intrathoracic pressure. If you try it yourself, that increases the intrathoracic pressure. And what happens is you have alveoli, the air sacs, get blown open by the backward pressure of the puffing. That changes the collapsed alveoli to being open alveoli. All of a sudden, the blood oxygenation goes up. You have less pneumonia. You have fewer bed sores. Activities of daily living soar. And you'll see in the results that this kind of thing, which is very simple, and it's one technique that we employed with chronic obstructive pulmonary disease. With diabetes, we employed going through the cabinets. This is very down and dirty and saying, eat this, not that, to steal a title of a book. But those home visits were incredibly important. Post-admission follow-up, in-home monitoring. I guess this is where they got the technology issue for name on our talk here. You need an electronic health record. Using the electronic health record, it's also important that it become a virtual single medical record. We use something called Care Evolution so that every type of electronic medical record can speak to every other type of electronic medical record. We asked the doctors in primary care to tell us what they wanted us to send them. So as a primary care doctor, I know if my hospital sent me a 600-page admission, I would not look at it. So I would say, give me the discharge summaries and the operative notes, that kind of thing. We developed risk profiles using diagnostic coding groups to identify the 3% of sickest patients. That includes pharmacy utilization. It's not just cost. Cost data is useful. You can look back and see who cost the most last year. That doesn't necessarily predict as well as who has the most illnesses and who uses the most drugs. That's very, very important. We were able to push population health messaging to patients saying you're due for your varicella vaccine. We were able to push messages to physicians saying your patient who's coming in tomorrow is due for the varicella vaccine. That's really helpful. We use ZINCs for clinical guidelines to define the types of care we needed, CPOE. And this last one, it's not a technological thing, but it's probably one of the most important things you could do in the ACO. Medicare alone spends $55 billion in the last 2 months of life on care of dying patients. Now, $55 billion is more than we spend at the federal level on the Department of Education and on the Department of Homeland Security. But we're spending in the last 2 months of life. We trained our doctors in a program out of England called Death with Dignity to learn how to talk to patients once there's a terminal illness. And we went from enrolling patients into palliative care 90 days after a terminal diagnosis to less than 30 days after a terminal diagnosis. So that cut out those last 2 of the last 3 months of extra care. And interestingly, what happens, you'll find in the literature, is when you put people in palliative care, for example, cancer patients, they actually live longer because they're not getting flogged with cancer medications. And they also report an improved quality of life, patient satisfaction soars, family satisfaction soars, and the cost of care plummets. $55 billion lost to Medicare in the last 2 months of life. This slide is very complicated, and I don't need you to memorize it. At first I said I'm not going to put it in because it's too complicated. By the same token, it's actually comforting to me because I feel that this is everything you need to know in order to run an accountable care organization. You need an electronic health record that's HL7 compliant. You need to know who's in your membership. You need the medical data, and you need care management data so that if the medical data aren't generated to show that the patient who needs a varicella vaccine got a varicella vaccine, then you have a problem. Whereas if you can compile and cross-tabulate membership data with care management data and diagnostic data, you can move forward. Physician imputation is really important. You need to know which physicians are costing the most. Now, typically, that's not primary care physicians, it's the specialists. However, we only imputed to the primary care physicians. We said, you're costing more money. And they'd say, well, no, it's because I sent the patient to the cardiologist. But that cardiologist has not especially wonderful outcomes and costs more. So we're dinging you for your outcome here. And they eventually learn to send to the highest quality cardiologist with the lowest cost. And this results in compliance across the continuum. The physicians who know that every dollar that they save, they're going to get split with the hospital 50-50, all of a sudden start referring to the lowest cost providers with the highest quality, the lowest readmission rates, the lowest recidivism, et cetera. And you apply patient care analytics to that, essentially clinical practice guidelines to assure that patients are getting the right care, and you're in good shape in terms of quality and in terms of understanding your population. Well, I've raced through this. I assure you that this is kind of a life's work for me between 2007 and 2012 when I started being a consultant. These data from 2009, I didn't bother to update the slide. They actually got a little better in 2010 and 2011. But look what we did with admissions. We went from 380 admissions per 1,000 per annum to 173 admissions per 1,000 per annum. Let me tell you what that means to a hospital that's in a full risk situation. Medicare paid us $9,980 for every DRG admission. And in order to earn that money, we spent $8,050. So we made $1,800 per admission. We had a very nice margin. We were very efficient. But if we didn't admit a patient, we kept that $9,900 and put half of it in our pocket, $5,000 in our pocket, and $5,000 went to the primary care physicians, and we didn't do any work. So that's much better than making $1,700, $1,800 and working your tail off. Our length of stay surprisingly actually went down in spite of the fact that we were admitting fewer sicker patients. And our hospital days decreased by significantly more than half. This data comes from the Tufts Health Plan. I actually didn't generate this slide. That's why I haven't updated, although I probably could. Well, if you add, I mentioned that we kept people longer in the ER, we used observation. So to be fair, I wanted you to see that we did use 301. If you added total admissions and observation, we had 301 encounters in the hospital setting of some kind. But look at what we did with 30-day readmissions by talking to Mary in the ER and asking her if she wanted to take the insulin and fluid. We went from 20.0 30-day admissions for Medicare patients to 9.8. When I spoke to the folks at Medicare, they told me anything below 10 is the holy grail, and so we were very pleased with that. What did this do to our finances? We actually got, in the first few years, we took our finances, we improved the bottom line by $5 million. That all went directly to the bottom line. By the end of 2012, that was $7.5 million. All that money was shared savings because of decreased admissions, decreased readmissions, and the like. We grew our primary care physicians from 43 in 2008 to 147 in 2010 because every physician in the Pioneer Valley where Springfield is located decided, gee, they wanted to participate in those savings. As a matter of fact, we distributed the savings based on how many patients the primary care physicians had. Some physicians got checks that were 6 figures. So, of course, when the doctors heard that Joe Schmo is getting 6-figure check for managing the ACO, all of a sudden everybody wanted to join. None of these people were employed. We won a number of awards for this work, cleverly designate us one of the 100 top hospitals in the United States for quality and efficiency. We won the ACHE Outstanding Innovation Award in 2010. We were Leapfrog Top Decile Hospital. And I told you about our hospital location. We became, out of 64 community hospitals, we were the most profitable community hospital in Massachusetts out of 64. And so these were remarkable results. The ACO, when done right, has tremendous possibilities. And I'll stop there.
Can you go back to that, my favorite slide, that graph slide?
With the money?
Yeah.
Bob loves money.
No, I love this this slide.
I made it green for Bob.
No, the other one, back before that.
Oh,
that
that's
one.
Sorry.
So look at this. Look at what he did. And this goes to my concept that all you got to do is move the needle a little bit, all right? So all this is saying is that the 3%, okay, the top 3% spent 49% of his budget. All they did through disease management, you look, it takes several years to get this done, by the way, but all they did for that 3% was move the number from 49% of the budget to 43% of the budget, okay? That's still a high percent of the budget, right? But that ended up being, what, $5 million a year?
Yeah, and over the next 2 years, just as I left, it was $7.5 million. So we got it down to 41% of the budget. And, you know, you talk about a $100 million program. This is real money.
Yeah.
And imagine taking the poorest hospital in Massachusetts, at least the hospital in the poorest city in Massachusetts, and making it the most profitable. I assure you there are a lot of hospitals in much better neighborhoods than the neighborhood I'm describing that 60 Minutes said is the most gang-riddled city in America. So there's a lot of hope there. And you know what's interesting to me about it is, for just this one ACO, we had another one with Fallon with similar results. We only concentrated on 150 patients. That's 3% of 5,000. But you know, when we did the Fallon ACO, that you just have another team. So you can scale this up to 100,000 patients or 500,000 patients just by having different teams and having different call-in numbers and different real-time physicians, et cetera. So there's a lot of possibility here. And you can make a lot of money and cut the cost. Here we cut the cost of Medicare by a little over 13%. It would be wonderful if we could do that over and over again across the continuum. Any questions? Yes?
Where he split the...
Yeah, I cut out. Bob knows my talk better than I do. He kept telling what I was going to say. We split between the primary care physicians and the hospitals. This was done through an IPA, so it was, we had a legal contract. 50% of all savings went to the primary care physicians, 50% went to the hospital.
And remember, he said that these are primary care physicians, and a lot of them got six-figure checks.
Not a lot of them, but
But
several,
some, but I
several
mean,
of them.
yeah, that's pretty significant.
The
Yeah.
incentives were just incredible. I mean, to go from a hospital where no physicians wanted to practice to one where most of the physicians in the Pioneer Valley of Massachusetts, about 90 miles from Boston, all of a sudden we had everybody join us because the savings were that strong. Now, we really were desperate because we were a hospital that was perhaps about to close. When I went there, people said, "What are you doing going there?" I mean, and I actually hit myself in the head when I got there and saw how bad it was. But the physicians were the key because they really bought into it. And not having any money, we couldn't employ people. So this was a model that was driven by desperation as opposed to brilliance. Other questions? Yes. Well, as you know, it's a violation not to refer to other organizations. But we own that organization. You have to present to patients a list of home care agencies in your area, otherwise it's a self-referral violation. But all we did was, instead of listing, actually it was the Mercy Health System, was the acute hospital, but it was the Sisters of Providence Health System was the name. So we had been presenting a list of home health agencies to patients alphabetically. So our prime competitor was listed number 1, Bay State, and Sisters of Providence was listed last. So we moved Sisters of Providence first, and we put Bay State last. Anybody from Bay State, you can, I'm sure you'll report this to the folks at Bay State. They're a wonderful hospital. Anyway, our referrals went way up, and we say, well, we like this, they do a good job, et cetera. So we were allowed to say that.
But even for the you had unreimbursed home care visits, right?
Yes,
Yeah.
yes, because, I
It
gave
didn't qualify.
Right, a respiratory therapy visit is not reimbursed, or a nutritionist to go through the cabinets and say, this is a high glucose thing, and don't eat white bread, eat multigrain bread. That isn't reimbursed, but it really helped a lot to the bottom line. It required a lot of, I guess, guts and desperation. Other questions? Okay, well, thank you very much.
Thank you. Couple minutes early.